We are talking about a rare but absolutely devastating anesthetic complication that honestly, every single one of us dreads, and it's one that carries a huge legal risk: malignant hyperthermia.
All right, so here's how we're going to break this down. First, we're going to jump right into a real-world lawsuit that, trust me, has some huge implications for how we practice. Then we'll get into the nitty-gritty science of what's actually happening inside the body. And we'll wrap up with a practical, step-by-step crisis protocol that, honestly, every one of us needs to know by heart. So our story today doesn't start in the OR. It actually starts in a courtroom. We're looking at a case out of South Korea that I think is essential for all of us to understand. Why? Because it really forces us to ask some tough questions. Questions about our duty of care and, what's realistic when you're preparing for something that might only happen once in 100,000 cases. Okay, take a look at this timeline. It just lays out such a tragic and frankly frightening sequence of events. You have a patient coming in for what should be a pretty standard C4, C5 discectomy back in May of 2022. Everything's routine, anesthesia is maintained with SIVO, and then it happens. The patient's temp spikes to a terrifying 40.5 degrees Celsius. The team, to their credit, figures it out. It's malignant hyperthermia. But then they hit a wall, a catastrophic one. The hospital doesn't have Dantrolene. They rush to transfer the patient to a university hospital, but it's too late. Despite getting the treatment there, the patient passes away. And as you can imagine, this led to a massive lawsuit that put our entire specialty under the microscope. So what is this thing that caused such a tragedy? I mean, we all know the textbook definition, right? Malignant hyperthermia is a pharmacogenetic disorder. It's this hidden genetic time bomb, just sitting there, completely silent, until we, the anesthesiologist, introduce a triggering agent. And then boom, what should be a safe anesthetic suddenly unleashes this runaway metabolic firestorm inside the patient's muscles. And these are the basics that really set the stage for this entire legal battle. The triggers? They're our bread and butter, right? Volatile gases, succinylcholine. The early symptoms are so sneaky. A little hypercarbia, some tachycardia, before you get to the classic rigidity and the terrifyingly high fever. It's so rare, which is what makes it so dangerous. And here's a scary stat. Over half of all these reactions happen in kids. But the bottom line, the one thing that this all comes down to, is that there is only one antidote: Dantrolene. All right, so let's get into the legal weeds. What was the central question here, and how does the court's answer affect us? The family was understandably devastated and angry. They went after both criminal and civil charges. Now, the police didn't find enough evidence to move forward with criminal charges, so this whole thing ended up as a civil lawsuit, a fight for damages. And really, the entire case boiled down to one huge question. Was the hospital negligent for not having Dantrolene in its pharmacy? That was the big one. But the family also argued that the diagnosis was too slow and that they were never properly informed of this risk. So let's pull apart how the court looked at each of these three crucial points. Okay, this table is fascinating because you can really see the court's thought process. It's surprisingly practical. First, the diagnostic delay. The court basically said, look, in hindsight, yeah, it took about an hour, but this thing is super rare and the early signs can be anything. So no, that's not negligence. Then, informed consent. The court decided an event this rare isn't something you have to discuss for every routine procedure. But the real bombshell, the part that has us all talking, was the ruling on not stocking Dantrolene. And to really get why the court ruled the way it did, you have to see this number: 622. At the time of this incident, that's how many vials of Dantrolene existed in the entire country. Just 622. Even the big university hospital they transferred the patient to only had 18 vials on hand. This scarcity wasn't just a small detail. It was a central pillar of the court's entire argument. And this quote from the Gwangju High Court really just sums it all up, doesn't it? They said, and I'm paraphrasing a bit, "It's unreasonable to expect a general hospital to keep a drug like Dantrolene in stock, considering its cost, how you have to store it, and how incredibly rare the condition is." And then, the key phrase: "This does not fall under the standard duty of care." A huge statement. So what's the big takeaway for us on the front lines? Well, it's definitely not to get complacent and think, oh, we don't need Dantrolene. No way. This verdict doesn't let anyone off the hook. What it does is highlight that this is a systemic problem. It draws a legal line in the sand between what's expected of a major tertiary center versus a smaller hospital. But what it really screams at us is the need for a bulletproof plan. If you don't have that drug in your building, you had better have a lightning-fast transfer protocol and know without a second's hesitation where the nearest stash is. This is all about regional coordination. Okay, So we've got the legal landscape sorted. Now, let's switch gears and put on our biochemist hats. Let's get down to the molecular level and figure out what is actually going on during an MH crisis, what makes it so violent and so fast. And more importantly, why is dantrolene our only weapon against it? So before we can understand the chaos of MH, we have to appreciate the beautiful, elegant dance of normal muscle contraction. EC coupling. It's that amazing process that turns a simple electrical signal from a nerve into actual mechanical force. And it all happens right there at the triad junction, that little meeting point between the T-tubule and the sarcoplasmic reticulum.
So here's how it's supposed to work. It's this perfectly timed sequence. An action potential zips down the T-tubule, which makes a protein called CAV 1.1 change its shape. That physical change literally nudges its partner, the ryanodine receptor 1, or RYY1, which is basically a calcium gate on the sarcoplasmic reticulum. The gate swings open, a perfectly measured puff of calcium flows out, and the muscle contracts. Then, right away, these little pumps called circa get to work, using up ATP to suck all that calcium back in, and the muscle relaxes. It's just a beautiful, efficient system.
But in malignant hyperthermia, that beautiful system is completely shattered. There's a mutation, usually in that RYR1 gene, that makes the calcium gate faulty and super sensitive. So when we introduce a trigger like sevoflurane, that gate doesn't just swing open, it blows off its hinges. And instead of a controlled puff of calcium, you get this massive, unstoppable flood. The cell is just drowning in calcium. The sarcopumps go into a frantic panic, trying to clean up the mess, burning through ATP like crazy and generating a ton of heat. That is the hypermetabolic crisis. The flood of calcium causes the rigidity, and this metabolic chaos is what leads to the acidosis, the rhabdo, and eventually the whole system just collapses.
And this, right here, is exactly why dantrolene is our silver bullet. It's not just treating the fever or the acidosis, it's going right to the source of the fire. Dantrolene physically latches onto that broken RYR1 channel and plugs the leak. It stops the calcium flood, which finally gives the pumps a chance to catch their breath, restore balance, and shut down that entire out-of-control metabolic cascade.
All right, let's talk genetics. Where does this faulty wiring come from? And how can we possibly find out who's at risk before they're on our operating table? Because really, understanding the genetics is everything when it comes to counseling families and flagging people who need a trigger-free anesthetic. So as you can see here, the lion's share of these cases, something like 80%, are tied to mutations in that RYR1 gene, the gene that builds the calcium channel itself. Sure, there are other genes involved, but RYR1 is the big one. It's public enemy number one. And knowing this is absolutely foundational to how we screen and advise families who've had an MH event.
Now, you might think, okay, so we just do a genetic test, right? Well, it's not that simple. Genetic testing doesn't catch all the mutations, so the definitive gold standard diagnosis is still a muscle biopsy and something called a contracture test. There are two main flavors, the European and North American protocols, but they both basically involve taking a piece of live muscle and exposing it to caffeine and halothane to see if it freaks out. The main thing for us to remember is that this is a big deal. It's an invasive test that's only done at a handful of specialized centers, and that's why getting a good family history during our pre-op is so incredibly important. We also have to be on high alert for other neuromuscular diseases that travel in the same circles as MH. If you see central core disease or King-Denborough syndrome on a patient's chart, that's a major red flag. They have a super strong link to MH, and you should plan for a trigger-free anesthetic, period. Now, things like Duchenne or Becker muscular dystrophy are a little different. They aren't technically at higher risk for a true MH event, but if you give them succinylcholine, you can trigger a massive hyperkalemic cardiac arrest and rhabdo that looks an awful lot like MH. So even though the biology is different, our practical response is the same. Avoid the triggers.
Okay, now for what is maybe the most important part of this whole discussion. Let's get super practical. How do we spot the storm on the horizon when it's happening right in front of us? And just as critical, how do we tell it apart from all the other things that can look like it? This right here is where our moment-to-moment vigilance really, truly matters. The absolute key to getting a good outcome is catching it early. And the very first clue, the most reliable and sensitive signal we have, is an unexpected jump in end-tidal CO2 that just won't come down no matter how much you crank up the ventilation. That is your canary in the coal mine. After that, you'll likely see tachycardia or arrhythmias. If you've given succins, you might see that classic jaw rigidity. But please remember this. The fever, the thing the condition is named after, is often a late sign. If you're waiting for the temperature to go up, you are way behind the 8 ball.
But of course, every time the heart rate goes up or the CO2 bumps, it's not MH. We have to be smart and run through a differential diagnosis in our heads. Could this be a thyroid storm, a PHIO? On the simpler side, is the patient just too light? Is it CO2 insufflation from a lab case? Could it be sepsis? The ability to think through these possibilities while simultaneously taking action is what makes us anesthesiologists.
Okay, let's bring it all home. You suspect MH. What do you do right now? Let's walk through the life-saving protocol step by step. This is the MHAS protocol, and honestly, a printout of this should be in every single OR, probably right on the MH cart itself.
The first phase is all about damage control. You've got to stop feeding the fire, and you need to buy yourself time. First thing, immediately, shut off all the volatile agents. Make sure no more sucks can be given. At the exact same time, you yell for help. This is an all-hands-on-deck emergency. Get that MH cart rolling. Then you slam the fresh gas flows to at least 10 liters per minute of 100% O2. You're trying to flush the gas out of the circuit and blow off all that CO2 the patient is producing. And you tell the surgeon, we need to finish up, now, as safely and as quickly as possible.
And here's a fantastic little pro tip for this phase. Ripping apart the circuit and changing the CO2 absorber takes precious time. If your hospital has them, these activated charcoal filters are a game changer. You slap one on the inspiratory limb and one on the expiratory limb, and they can suck the residual anesthetic gas down to almost nothing in less than 2 minutes. That's way faster than just flushing the machine. A really slick move if you have them.
All right, so you've stabilized things for the moment. The next step in the protocol forks into 2 completely different paths, and the direction you take depends entirely on one single question. The same question that was at the heart of that lawsuit we talked about. Is there Dantrolene in this hospital? Yes or no? Your entire plan from this moment forward depends on that answer. And you can see the 2 pathways laid out perfectly here. Pathway A, you've got the drug. Your mission is simple. Get it mixed and get it in the patient as fast as you possibly can. Pathway B, you do not have the drug. Your new #1 priority above all else is to get on the phone and arrange an immediate stat transfer to a hospital that does. And while you're arranging that, you're doing everything you can symptomatically. Cooling blankets, treating acidosis, managing potassium. So if you're lucky enough to be on Pathway A, you need to know how to give this stuff. The older version is a bit of a pain. Each little 20 milligram vial has to be mixed with 60 milliliters of sterile water. You're going to need a lot of hands. The newer Ryanodex is much faster to prepare. The starting dose is an IV push of 2.5 milligrams per kilogram. But listen, that's just the starting dose. You may need to give a lot more. You keep pushing it, up to 10 milligrams per kilogram, or even more, until you see those numbers start to turn around, the end tidal coming down, the heart rate settling, the muscles relaxing. At the same time, you're fighting the other fires, bicarb for the acidosis, and insulin and glucose for the life-threatening hyperkalemia.
And please burn this into your brain. This is a huge, critical safety warning. When you're trying to treat the crazy tachycardia you see in an MH crisis, you cannot, under any circumstances, give a calcium channel blocker like verapamil or diltiazem if you've given dantrolene. The combination is absolutely lethal. It causes catastrophic hyperkalemia and total cardiovascular collapse. It's an absolute non-negotiable contraindication. And even when you've got the initial fire put out, you're not out of the woods, not by a long shot. That patient needs to go straight to the ICU. Why? Because of something called recrudescence. The crisis can actually come back. It happens in up to half of all patients, usually in the first few hours. That's why we keep giving dantrolene, about 1 milligram per kilo every 4 to 6 hours, for at least a full day. In the ICU, we're watching everything like a hawk. Core temp, urine output for signs of rhabdo, searing from it.
So let's wrap this up where we started. That court case gave us a clear legal answer for one specific hospital in one specific situation. But it leaves us, as a profession, with a much bigger, more uncomfortable question, doesn't it? Does this legal ruling create a real-world safety gap? And what is our collective professional responsibility, not just as individuals, but as a specialty, to build a system that guarantees every single patient, no matter what hospital they walk into, is just minutes away from this life-saving drug? That's the question I'll leave you with. Thanks for tuning in.